Hello, everyone, and thank you for joining today's webinar, The Evolution of Virtual Critical Care and Remote Monitoring in a Post-Pandemic Era. This webinar is sponsored by Medical Informatics Corp and Intel. Over the past year, Intel and Medical Informatics Corp, MIC, sponsors of this webinar, have been helping hospitals across the country get access to bedside waveform data that is typically thrown away to help empower a new standard of data-driven care through their Scale to Serve initiative. The program provides a mechanism to leverage MIC's FDA-cleared sickbay platform to enable flexible, remote monitoring and virtual care workflows across devices and clinical settings, as well as the development and deployment of patient-centered AI, all on a singular, interconnected, scalable, vendor-neutral architecture that also helps reduce costs, increase revenue, and improve operational efficiencies. More information is available at michealthcare.com. I'm Sean Edwards from World Congress. I'll be introducing our webinar today. Just a couple of quick announcements before I hand things over to our moderator. I'd like to explain how we're handling questions. Due to the number of attendees, participant lines are muted. However, if you'd like to submit a question for our panelists, please do so using the Q&A feature that you see at the bottom of your screen. We'll answer all questions that we have time to address during our program today. Also, please note the webinar will be recorded. You'll receive an email with a link to the video so that you can view it again. I'd now like to introduce our speakers for today. Dr. Emma Faust is the moderator. She is the co-founder and CEO of MedInformatics. David Lee is the Director of Clinical Information Systems at Johns Hopkins Health System. Emily Yoder is an analyst at CMS. Ken Leckerman is the Chief Information Officer at Houston Methodist. And Dr. Barbara Jo Acuff is the Assistant Professor, Department of Pediatrics, Cardiac Critical Care, Baylor College of Medicine, Texas Children's Hospital. Thank you all for being here. Without further ado, Dr. Faust, I'm going to turn it over to you.
Thank you so much, Sean. Welcome, everybody. Very excited about the esteemed panel today. It's actually a very unique opportunity to see different stakeholders across these really world-renowned institutions come together and talk today about virtual care and how, in some cases, these institutions, these leading institutions, were getting into virtual care well beyond the pandemic, how the pandemic changed and accelerated some of their initiatives, and really look at the future of where this is going in terms of both inpatient and outpatient virtual care. So with that, I'm going to first turn it over to the panelists and let them briefly introduce themselves, and then we'll jump right into the conversation. So Ken, why don't you start off?
Thanks, Emma. I'm Ken Leckerman. I'm Chief Information Officer at Houston Methodist here in Houston. We're an 8, soon to be 9 hospital system located in the Metro Houston area, and we have 26,000 employees. We've been in the news quite a bit lately, so you may have heard about some of our push towards getting all of our staff vaccinated, which I'm happy to report we have. Unrelated. I've been working with Emma and MIC for some time, and our journey began early with virtual ICU. And I don't know, Emma, how much you want to talk about our relationship with the product yet, but I'll just leave it as an introduction for now, and we can come back to that later
on. Barbara Jo.
Hello, everybody. So I am an assistant professor at Baylor College of Medicine, but I work 100% of my time at Texas Children's Hospital in our 54+ bed cardiac intensive care unit in the Legacy Tower in the medical center in Houston. Very busy place. We actually are #1 in the country for cardiology and congenital heart surgery. In those 54 beds, we have the most bypass cases a year of anywhere in the nation, and it's a very busy, active place taking care of babies from their first hour of life all the way through adults who have congenital heart defects, those who have acquired heart disease, and like I said, transplants and mechanical support devices. So a active, busy cardiac ICU, very well data-driven and connected, trying to use the highest level of technology to give us highest level of quality of care for our patients.
Thanks. David.
Thank you, Emma. My name is David Lee, and I'm one of the IT directors here at Johns Hopkins Health System for Clinical Systems. I've been with the organization for 30 years. We are a 6-hospital health system along with a university. We're actually founded, the university was founded in 1876 and the hospital was founded in 1889. I'm pleased to be with you today.
Thanks, David. And Emily.
Hi, everyone. I'm Emily Yoder. I'm an analyst at the Centers for Medicare. I work on physician payment policy, and specifically for the past 5 years, I've worked on physician payment policy for Medicare telehealth and other services that use communications technology. I was really involved particularly at the start of the pandemic with a lot of the waivers and sort of interim final flexibilities that CMS put in place to assist in sort of uptake of telehealth during the public health emergency.
Thanks, Emily. So I wanted to start off our conversation by really level setting and talking about what is sort of virtual care for your organizations pre-pandemic, right? I know a lot of you sort of your institutions dabbled in sort of what does virtual care mean for an inpatient setting, an outpatient setting, and we'll get into the pandemic and how that accelerated things in a bit, but let's start off first with that sort of concept. Where were you pre-pandemic? What does virtual care mean to you? Why is it important for your organization? Or why was it important for your organization? Ken, let's start off with you again.
Thanks. So virtual care was important to us actually before the pandemic, and then became critical to us during the pandemic. We had a project to implement a virtual ICU, and that involved our innovation officer, Roberta Schwartz, myself, and our intensivists, of course. And that actually went live in January of 2020, right? That's when we went live with that, Emma? And we went live initially with 24 beds, I believe. It was a small implementation with a planned gradual rollout throughout the year, which got rapidly accelerated because of COVID. And today we have 351 beds and carts all available for our virtual intensive care systems. So.
And what were some of the drivers for that, Ken? Like, why was your institution well on its way to looking at consolidation through like a command center? What was the? I mean, well, you're an executive, right?
Yeah,
so we see this from a very different level.
Exactly. We had been exploring opportunities for remote physiological monitoring, right? And we've been working together, of course, with you and in parallel to TCH and other institutions kind of in the Texas area. We were able to, when we expanded our business case to include some of the deterioration models and some of the other kind of systems that were ancillary to physiological monitoring, we actually were able to make the case to implement that technology whole across the entire system. And that was one of the biggest kind of, let's call it, discoveries in the development of the business case, was that we could actually, if doing it well, we could actually justify expense for remote physiological monitoring to enable our virtual ICU, which is frankly was before the pandemic I would argue was a little bit more of a difficult sell, right? And now, of course, after the pandemic and during the pandemic, it's kind of somewhat obvious, well, boy, we really needed that. And so we were fortunate that we were a little bit ahead of the game. But yeah, the business case that we made really included rationalization of the products, and also included including those deterioration models that we had, and kind of amalgamating them all into one system. That's where we've really benefited from the system, the sick bay system.
Thanks, Ken. David, we were talking before, and you mentioned that Hopkins has had a long history of dabbling in virtual care. Could you give us a little bit about that history?
Sure, Emma, thank you. Interestingly, one of the first ICU systems I managed was on our SICU and cardiac SICU, and two of the interns at the time had become attendings and actually founded a virtual ICU company years ago. And we had hoped back then, back in the mid-90s, that we would actually have virtual ICU across Johns Hopkins Medicine. But through a combination of challenges, both funding, financial challenges, resource challenges, and just political challenges, we just were never able to sort of come up with an agreed upon approach to proliferate that across the health system. We do have virtual ICU-like setups in our PICU at Johns Hopkins Hospital and some other areas throughout the organization, but as an organizational enterprise-wide solution, we just hadn't gotten there. And so Over time, we've used a number of different tools to provide virtual care. We have a remote patient safety observation system where a camera can be deployed to patients who are at risk for falls or other harm. We have done virtual video visits using our main EMR Epic. And that was exploded during the pandemic. We had something like 150 visits a month pre-pandemic, and then we've got over 4,000 a month now, and we expect that to continue down the line.
Thanks, David. Barbara Jo, you have a very different view of this. You're on the front lines. What was it? What was the concept? Did you guys even talk about virtual care in your practice pre-pandemic?
So I've been at Texas Children's for 6 years, and pre-COVID, pre-pandemic, we were using sickbay for different reasons. So one particular reason, we were using it for historical review. So every single heartbeat, every single blood pressure, every single breath was recorded from our from our GE monitors at the bedside. Actually, we have many, many monitors on these patients with their complexity of and acuity of their care. So then all of that is being recorded on the sickbay platform. And so the terabytes and terabytes of information being recorded, we would go back and review in a historical fashion. So if we had an event, if we had a cardiac arrest, we could look back and see what did that look like before the arrest, and how could we then change our practice for that patient in a preventative kind of fashion. So also in a predictability fashion. So research was being done on that recorded sickbay data, in that trying to find relative risk and predictability for even some of our most fragile single ventricle patients. Could we predict when they were going to have a deterioration before they had it? And so there was research going on with all of that data, very rich, high fidelity data, down to seconds and half seconds. And so research papers are being done on different events in the ICU historically. We also had, because we're such a spread out unit and such a big hospital, and sometimes when you're off floor, you could actually pull up sickbay off floor and actually do some remote monitoring when you weren't actually in the unit. So some of us had been in the habit of doing that, but not everyone. And so it was familiar to us, but not in and ingrained in our practice. If that makes sense.
Yeah. And Emily, talking about CMS and sort of your guys' view about virtual care, can you talk about that sort of pre-pandemic and before some of the changes occurred?
Yeah, sure. So there's a couple sets of circumstances under which Medicare pays for virtual services. And I want to sort of at the outset underscore that Medicare has some sort of specific rules regarding the circumstances which we pay for virtual services that don't apply to other payers. So I think that while there's certainly a lot of movement in the Medicare space right now about sort of changes to how we, telehealth and virtual services and things like that, and payers often will look to Medicare as sort of an example, it is important to keep in mind that these are just some Medicare specific sorts of things. So the first way that Medicare pays for virtual services is through Medicare telehealth. Now, Medicare telehealth is a specific sort of defined in statute set of services that are ordinarily furnished in person, but when a bunch of conditions are met, including outside of the PHE, the beneficiary has to be in most instances in a rural area, they have to be in a medical facility, so not in their home. There's a specific list of practitioners who can bill for Medicare telehealth. There's also actually enumerated in the statute. So these are services, when all of those conditions are met, that would ordinarily be furnished in person, but are instead furnished in full using two-way audio-video communication technology. So basically what this means, if you have an office visit, it's the exact same service when it's in person or when it's telehealth. It's done through two-way AV. So that's Medicare telehealth. Then on the other side, there's sort of what we call inherently non-face-to-face services. And these services fall outside of Medicare telehealth because they're not defined as services that would otherwise have occurred in person. So these are things like remote physiologic or remote patient monitoring, remote interpretation of diagnostic tests, care management services, e-visits, virtual check-ins, et cetera. And I will say that in the past few years, Medicare has come a long way in terms of expanding the range of these sorts of services that we offer.
Fantastic. Well, let's jump in and talk about sort of the pandemic and sort of how that changed things for you guys. I know that it affected your different institutions. What I'm particularly interested in, again, from your different views, right? We have executive, we have people in the middle of the tech part of this, we have people on the front lines, we have somebody looking at the reimbursements. What did the pandemic do to change your organization's view of virtual care or accelerate what you were already doing? Who wants to go first?
I can go first.
Okay, go for it.
So pre-pandemic, a lot of our emphasis on technology and care focused on enterprise-wide deployments of medical device integration, for example. So we had historically had physiologic monitors integrated as far back as the 90s, as I mentioned earlier, and it was only the monitors. And then over time, we added anesthesia machines in the ORs in addition to the monitors. And when you do a big bang deployment of integration on those kinds of product lines, it takes a lot of money, a lot of time, and we were seeing the evolution of different systems over time as well. And with the pandemic, the importance of getting vital sign information and especially waveform information became hyper important. So where in 2018, we initially deployed sickbay at our one unit, the neurocritical care unit in the JH Hospital. We all of a sudden emergently were asked to explode our deployment to over 140 beds in very quick succession. And by doing a lot of pre-planning, we were able to bring online physiologic monitor integration and ventilator integration in a very compressed time frame to allow our providers the ability to access that physiologic data, machine data, and assess a patient's conditions, not only within the hospital, but also from home using a secure cyber connection using VPNs. And so that was really transformational for us in terms of providing care.
And David, just to follow on with that, what was the impact to your team? I mean, IS is always sort of stuck in the middle between, you know, having the needs of the bedside versus making sure everything keeps operating. Like, what was the pressure on your team for this sort of shift in demand? How did you guys just react? I mean, how did you do it on the ground?
Yeah, well, I will say for the group, for the benefit of the audience, I only have a 3-person team with a manager managing them and another team that does medical device integration for the enterprise in terms of the middleware connections. And the good news is that they were a solid team. They've been together for a long time, some of them with me for more than 20 years. And so they already knew how to do these kinds of deployments, but this was a different animal, right? We had to do it quickly. So the other thing that was beneficial for us is we had the right relationship. So when you do a deployment like that, it's not just a single person or a single team initiative, right? It's IT working in hand in glove with clinical engineering, working with facilities, working with the clinical providers in the front lines. And so we had just enough notice that we were able to do a little bit of pre-planning and do some parallel efforts while we did contract work and funding and acquisition of assets. We were also able to sort of do some behind the scenes kickoffs and do a lot of the project management decision-making in parallel. So we literally became live within 3 days of the contract signing. And that was about 2 weeks after we were asked to do it. So it was pretty quick.
Yeah. And Ken, you went through something similar on your organization too. There were a lot of demands on your part of the organization and you had to make quick decisions. How did sort of the pandemic shift things and accelerate stuff for you guys?
Well, I think, you know, very much in alignment with what David talked about, you know, the focus on the response to the pandemic really was the driver. And, you know, I was fortunate, with regards to medical device integration, we already had it integrated, right, pre-pandemic. So that was the one lucky thing. We didn't have it rolled out across the scale of the institution, but we had it all integrated. We had already onboarded, you know, the product. We had the product for some period of time. And in fact, you know, so our pandemic response with regards to, you know, at least our virtual intensivists was to accelerate. And that sometimes that's, you know, I bringing a product in and having it running in a week. We were fortunate that we didn't necessarily have to do that with you know, certainly with sickbay or with some of the virtual intensive care products that we were integrating. However, we did have to roll it out, and that meant going into, you know, rooms, right, to install AV equipment and things of that nature. So those are the types of logistical challenges that we faced. Were more about scaling our operation versus onboarding and contracting.
Barbara Jo, I understand that it truly transformed things for you and your practice, your daily practice. Can you talk a little bit about what happened with in the front lines?
Yeah, so I wanted to just echo that we were very lucky because we already had the integration since Legacy Tower in September 2018 opened. So all of our waveforms and ventilators and all monitors were already integrated. So that was also an incredibly lucky thing because March 2020 became a very scary time. You know, you have to have agility and flexibility within a very large team. But most importantly, we needed to keep our staff free from disease while they cared for the diseased. And so how do you do that? And so, like I said, with some agility, we had to pivot. And already, you know, using the existing platforms was essential. And then into that new practice, it had to happen very quickly and become very well orchestrated so that we didn't have any pause or any, you know, gaps in our ICU level of care. So as an attending at the bedside, you know, I need to care for that patient the same way the day before lockdown and the day after lockdown. And then as we became even more COVID units opened and we became even an adult hospital at times with adult COVID patients in Texas Children's Hospital, the flexibility needed to continue. But the quick pivot to using sickbay in a manner that brought all of the knowledge sharing together in a quick fashion was essential. So, you know, an example, we usually, you know, in an old fashioned kind of way, 10 or 12 of us would round every morning at 6:15 at each bedside with the patient at the center of rounding, as you can imagine. And then you'd have to have all the expertise at that bedside, surgical, intensive care, pharmacy, nursing, everyone at the bedside. And 10 and 12 of us would walk around to every single bed every morning. Now that couldn't happen with social distancing and to keep our patients safe. So that moved into a different platform room where then we could share the sickbay real-time, high-fidelity data as if you were looking at the monitors in the room over then a web-based interface. So then everyone could still continue to share and actually add more and more specialists to the review of that data. So all of our decisions are very data decision, but the patient could still stay at the center. And so as you're speaking and presenting a patient, the sickbay data is across the screen in real time. And that, continued, that allowed us not to have a single pause or gap in our care. And that was essential. So that clinical distancing rather than social distancing, allowed us to care for those very highly critically ill children and adults and not change any quality of care. So, and keep our staff safe because they needed to continue to work. And as our census grew and grew, we needed to continue that. So that's how we did pivot. And like I said, really fortunate. And sickbay became, instead of the historical review, as I talked about pre-COVID, it became front and center, continually keep the patient in real time, and real-time data review was really incredible. And then the 10 to 12 patients who were, or 10 to 12 providers who were rounding on that patient really grew to 20 and then 40. And now we can have patient conferences up to 112, 120 patient, providers and specialists all reviewing the data at one time in real time. And that's an incredible addition to our practice that has allowed a lot more collaboration and knowledge sharing. So hopefully that answers that question.
And Emily, looking from CMS, I mean, clearly CMS opened up a few things when the pandemic hit. How do you sort of what happened and how do you see that going forward?
You say we did a few things. We did 20 years worth of policy making in about 2 months because that's roughly how old the Medicare telehealth benefit is. So essentially basically CMS's thinking at the start of the pandemic was we need to get our payment regulations just sort of out of the way to allow clinicians sort of the most flexibility possible in terms of, keeping beneficiaries home and keeping themselves safe. So we had a couple different tools that we could use to do that. The first tool was they're called 1135 waivers. Basically, Congress gave CMS the ability, well, the secretary specifically, but CMS, to waive all of the statutory restrictions. And so there were 2 sets of waivers. And in the first set, we were able to waive the geographic and site of service restrictions. So this meant that beneficiaries did not have to be in rural areas. And most importantly, beneficiaries could be in their homes. And then we also, with a second set of waivers, waived the list of practitioners that can furnish, so that any practitioner, regardless, if they can bill Medicare, they can bill for telehealth during the public health emergency. And we also allowed for certain services to be done using audio-only communication technology, in recognition of the fact that, particularly for the Medicare patient population, they may not have access to, due to things like broadband, or just maybe don't want to use, the sort of 2-way audio video that we've required. So all of that was done with waivers. And then we also undertook emergency rulemaking. So there have been, I think, at least 4 interim final rules, but the stuff pertaining to telehealth is mostly in the first 2. And so this was in March, and at end of March and end of April was when these 2 IFCs came out. And so most significantly there, we added services to what we call the Medicare telehealth services list. So this is a list of CPT codes and HCPCS codes that are all of the services that can be paid for using, when done using Medicare telehealth. And so in the past, prior to the pandemic, we would, through the physician fee schedule rulemaking process, we would sort of take, we would add a few services here and there. But at the start of the pandemic, I think we added like over 100 services to that list. And then in the second IFC, we added more. I think that the total is we've added about 300 additional services to the list for the public health emergency. And our thinking there was that if a clinician comes to us and says, I am doing this service using telehealth and it's not on the telehealth list, like, can you please put it on the list so that I can get paid for it when I'm doing it as telehealth? Like, we felt that that was sufficient to sort of, and that the need to reduce exposure risk was so great that rather than sort of that would be sufficient in terms of our justification for our regulatory process for adding it to the list. So I think that that's been sort of the biggest piece of rulemaking that that CMS undertook in response.
Fantastic. Thank you so much, Emily. Okay, well, we're going to jump in. I want to sort of split off a little bit here and talk to Ken and David, particularly about implementation. We have a lot of different of your peers on here, and I want to get into the sort of nuts and bolts about what makes virtual care practical and what the implementation looks like. So I guess, Ken, from your perspective, costs, challenges from, doing projects like this within your organizations, what are the decision-making things that are really important to focus on? David, device integration, the actual logistics, what do you need to integrate? What are some of the challenges you face on the ground doing the actual work? If you could both address that. I mean, Ken, let's start with you and talk about from the executive view.
So we're, every investment that we make at the size and scale of any virtual intensive care investment, requires quite a bit of scrutiny. This one was an interesting one because initially we were looking at it, we had the same experience with the aggregation of data and the remoting of that data, and we understood the value. What we had to do was then look and say, kind of build the business case. And it was one where, as I talked about earlier, we had to expand some of our thinking about, well, what products are kind of in this domain that we could include in our analysis in the business case. I hope that makes sense, because we expanded it to include things like deterioration algorithms and models that we had purchased for kind of single use or for one particular set of users. And when we did that, as we understood the capability of the integrations that we were going to implement, the business case kind of started to make itself. And that was the pitch. The pitch was, hey, we can invest in this remote physiological monitoring solution. It will, exposes alarms and waveforms and all the things that others have been talking about. It allows us to remote them to our virtual intensivist, and it allows us to build the alarms and models on top of it, which we've done with you. And so that has been that was the fundamentals of the business case from a start to finish, is recognizing, boy, this looks really powerful. How do we sell it? to then identifying all the things that it could, potentially be part or be part of the business case, and then building that business case and selling that business case.
It sounded like consolidation. The two things that stood out for you is like from an IT perspective, like consolidation of different clinical applications and infrastructure so that you could streamline that and operationalize it.
And we did that. And we worked with our CFO and with my boss and our chief innovation officer, who is awesome. And the three of us worked hard and really looked at it. And after all of that review and after all the consideration and looking at the numbers, it was approved. And so that was the way that we moved forward with it. And then, again, it was I would describe it as a rigorous process, as with many of our investments, but one that we're really happy that we made, and one that has proven to realize the benefits that we were expecting.
Fantastic. And David, talking about implementation and what are some of the challenges you guys have faced in the area of virtual care?
Sure. So I really think about it in 4 different categories. The first one is, what problem are we trying to solve? And when we look at technology solutions, first and foremost, we need to make sure that it's going to solve the clinical and operational problems that are being posed to us. The second one is, do we already have tools in-house that'll serve this need? And we're looking to bring in another tool. Is it compatible with those tools? And is it something that we can integrate and implement in a successful way? The third one is about ease of implementation. It doesn't meet all of our standards for Johns Hopkins, right? So everybody's very keenly aware of the concerns about cybersecurity these days, about the Hippocratic Oath for physicians, do no harm, first do no harm. We need to make sure that before we implement any kind of technical solution, that it meets our cybersecurity standards, that it's compatible with the standards that we've established for any kind of technology deployment. And then finally, we think about support, right? So not only can we install it in a safe and successful way, but is it sustainable after the initial install? The job isn't done just when you go live with the new technology. It's, is it going to be something that we can sustain and maintain safely, given the human resources we have, the technology expertise we have, and the funding that's attributed to and available for that particular project. And actually, there's a 5th category that's really hot for us now, which is for years and years and years, we did a lot of what I'll call siloed deployment of technology. So, our community hospitals may have chosen solution A for a particular problem, and our academic hospitals may have chosen solution B. And we're really trying to make sure that we look at these solutions on an enterprise-wide basis and only allow differences across hospitals when it's either clinically, operationally, or justifiable. The variation is justified.
Thanks, David. Now going to Barbara Jo and Emily, let's talk about some of the challenges. Let's start with Barbara Jo. Challenges to adapting to virtual care. What are the type of struggles that frontline providers face with integrating these technologies into their workflows?
Well, certainly when you're used to being right at the bedside with the patient, and now we have to be distanced from the patient a bit, and distance from our specialists, our sub-specialists that care for us, so we need to speak to them in a virtual manner rather than right at the bedside. And so rather than a scramble to find the data, we've actually been able to have that all consolidated in one place. So the SickBay platform really does allow us to review, like I said, the real-time hemodynamic data, and then, put that with our EHR, put that with our record at the same time, then you can really look and review the data together. The challenge is, then there's one good thing about that is you can, send a Zoom invite and get on a call with somebody right at the time, but then, there's still always that timing. Rather than in the unit and I'm busy and I can't jump on a call, to review this with you, everybody used to be right there with you. And now it's a little bit Twilight Zone in the unit. There's no persons, there's no physical humans around, right? So everybody's, available electronically, but not necessarily available physically. They were when we needed them, don't get me wrong, but it was just a little bit of a different challenge. So we adapted to that as necessary. And but the plugins, we had everything at our fingertips, sometimes more waveforms than we even needed. And so, and then we were able to even plug in more technology and hemodynamic monitors and Swan GANs and all kinds of things to the sickbay to get it recorded and shared among others. So, in one way it's challenged because I want to add this other monitor, but I really want it on sickbay so someone else could see it. So we still need to get that plugged in. And so, there were definitely challenges in it, but much more easily overcome because we were already plugged in to the sickbay platform.
Thanks.
And I'm really grateful to have real true humans physically in the unit now. So.
Well, Emily, looking at what you guys have already done around the reimbursement codes and things like that, I know that a lot of the waivers are temporary. What do you think the challenges are for going forward and continuing to enable this sort of virtual care modalities within the reimbursement system?
Sure. So a great sort of privilege and a bit of a burden that I have when I do these sorts of panels is I hear all about this like really wonderful, really innovative sort of models of care delivery. And then I have to ask the question, how do we code for this? How do we pay for it? So I wanted to speak actually specifically to tele-ICU for a minute, because that's sort of, obviously it's what the panel's about. And so right now we don't have CPT codes that really describe the full range of this service that you all are articulating. My sense right now is that it's being reported through a combination of like remote monitoring codes, and then through telehealth, through things like critical care consults, inpatient services, and sort of ventilation management when done using telehealth. So CMS is really, really interested in this model of care. Last year, we actually did a comment solicitation on tele-ICU, and we really do look forward to if and when, hopefully, our stakeholder community, submits recommendations in terms of like how to code and how to pay for this service. And that's just a general problem, a little bit with just fee-for-service Medicare in general, is that everything has to be boiled down to, because we pay based on a code, and each code is supposed to describe a specific service. It has to be boiled down to like, okay, here's a specific service that's furnished to a specific beneficiary in a specific way, and that's all in the code. And that becomes really challenging as you're sort of thinking about sort of longitudinal care or things like care management, or where there's sort of where you're sort of delivering care to beneficiaries simultaneously. All of those are really, really, like, those are just very challenging for fee-for-service Medicare in general. In terms of what CMS is sort of thinking broadly about the flexibilities, as you said, many of them are statutory, and so those would require an act of Congress. That's the geographic and site of service restrictions. In terms of what we have regulatory authority over, in last year's physician fee schedule, we sort of put out our first sort of, I want to say the sort of what we hope is the start of a conversation with the stakeholder community, where we said, okay, here are some services that we think have potential to be permanent telehealth services, but we recognize that right now clinicians are really, they're focused on treating patients. They're not focused on gathering the kinds of information that CMS would look for to justify addition to the telehealth list on a permanent basis. And so we extended those for a period of time after the public health emergency is declared over, just to allow for clinicians and other stakeholders to develop recommendations and to submit those to CMS.
Great, thanks, Emily. So let's jump in, before we jump into Q&A, let's talk a little bit about, again, where Emily was going in the future. How are things going to evolve in this space? What does virtual care start to look like for each of you guys as we go forward? And it's not just about directly, I think we've talked a lot about directly viewing data, but Ken, you started talking about, your organization's drive to actually build and deploy custom analytics. What does virtual care mean to your organization? I also know that you've also invested in virtual care beyond the ICU as well. So, like, again, how are you looking at it from a corporate strategic perspective?
Sorry, I was typing an answer to a question too. So, but yeah, well, we've been talking largely about acute intensive, virtual intensive care. And we're looking at these technologies across all of our delivery channels. And, we're looking at centralized telemetry as an example across our hospitals. We're also looking at virtual ambulatory and outpatient expansion. And that's something, of course, I think everybody's probably had the same experience that, we were doing virtual outpatient visits at some scale pre-pandemic, and then that just exploded during the pandemic and hasn't fallen back to the original volume. I mean, we've some of that volume has come back to the office, but we see that continuing. Then there's other models of care that are being talked about, hospital at home. One can easily imagine where you get, this ability to remote real-time alarming and real-time physiological data and waveforms anywhere is empowering, right? And that was the first thing I heard. I heard others talk about is that, and that's what we got hooked on that too immediately, right? Is like, wow, this entire data set and this historical data set. And it was described to me like, the this ability, we were flying a 747 without any instrumentation. And now we have, terabytes and petabytes of information about these patients that are in our systems. And that can be used both for the direct delivery of care, as we've heard today, and also for the review of the information and, kind of post-event review as well. And I've heard a lot about that. That's the future, in my opinion. It really is. And the expansion of all those services, across acute and outpatient delivery channels is going to continue. That's just, obviously my opinion, but I think the writing is on the wall. I would welcome others' comments on that. Yeah.
I was going to say, do you also believe it's going to be part of your competitive value proposition as an organization? I mean, you guys are leaders in Texas and definitely ranked nationally. That's got to be fierce competition. You live in a medical center that you're surrounded by other hospitals.
Yeah, we do. Well, we do, and it's a really great place to be in health IT, frankly. I mean, and to be in healthcare. And I feel fortunate for that. But yeah, I mean, virtualization is a platform that allows us to extend services. It allows others to extend services, right? We have to look at, and we've been spending a lot of effort on looking at what is the experience. What's the experience of the clinician? What's the experience of the patient? What's the experience of the family? And both inpatient and outpatient. How do we transition those experiences? So yeah, that and I think done well, I think that creates a great experience for anyone interacting with your health system, right? And so yeah, the answer to your question is yes. I mean, we see it as something that we're competing on. Virtual care is something that we're all competing on. How do we do that the best? And a lot of the barriers are gone now, which is really awesome. Because the days of creating the demand for that service are done. Now it's okay, how do we do it better, faster, right? How do we make it easier? How do you make scheduling easier? How do you make changing that easier? I mean, all of these different things from an outpatient perspective are things that we're looking at.
Fantastic. Who else wants to join in and talk about the future here? What you guys see?
So like I said, I think that the sickbay platform and all of the terapetabytes of all kinds of servers full of historical information, way back to when we first implemented it, is this incredible, rich, almost delightful data source that we can go back and look at and then, build predictive models from deterioration and, then look at and build other algorithms on to find out what the events in the ICU affect the child hemodynamically, different than we had thought previously. What we thought was pretty benign, we're finding with the review of the sickbay data that's historical, we're finding it wasn't maybe so benign. And can we change our practice to be safe? And so that historical data is, like I said, incredibly rich, and we are learning more and more about how to use it. And then the real-time data that I said now it was in our back pocket. We knew about it. We were using it somewhat, but now it is front and center. It's in our toolbox. I believe that it certainly has enriched our practice. We went into crisis mode for COVID, but I believe that using the sickbay platform in our everyday practice has only enriched it, such that really for the benefit of the child. It's going to continue to be in our toolbox every single day with patient conferences and with patient review and subspecialty review over a virtual platform rather than always at bedside. I believe it'll be more of a hybrid model that you hear about corporate saying in the hybrid model. I think we're going to adopt a hybrid model from here on out and always be using it in our toolbox. That SickBay platform, like I said, has always been fantastic and now has really just become much more, even more enriching. So I think it just moves us along and accelerated. I think we would have gotten there. I think COVID actually has done a lot of good for our practice in a way. It sounds so crazy to say that, but it really has accelerated a lot of things. I think we would have gotten there, but we've gotten there much faster in the use of technology.
Thanks, Barbara Jo. And Emily, David, do you want to add anything about what you see the future of virtual care and how that's going to evolve beyond just getting access?
Sure, I'll just say really briefly from sort of the CMS perspective, like obviously, like utilization for telehealth has really gone up during the public health emergency, and it's clear that it's really important. And the agency really recognizes how important it is. And while I can't of course speak to what we're going to be doing in the future or anything like that, I will say that it is probably going to remain sort of a priority for the agency as well.
And I would just briefly add that to me, it's almost a matter of which value proposition you're going to focus on, right? So I think that the pandemic and the use of technology and virtual tools basically transform the expectations, both from the patient's perspective and from the provider's perspective, right? So what you expected to have as an interaction with your provider pre-pandemic and before you had to rely on these remote tools is much different than what we have today, number one. Number two, right, the expansion and explosion of the use of technology, right? Everybody's got Fitbits or Apple Watches or Samsung Watches or smart devices, and the ability to sort of capture data is growing exponentially. The bigger challenge then becomes, well, what data do you focus on? What data do you trust? And how are you going to use that data? And so I think virtual care is going to continue to grow and evolve with the evolving expectations of both those providing the care and those receiving the care.
So David, with that, actually, it sort of leads into one of our questions from the audience. I think there was some interest in terms of what kind of data is included in virtual care. I know we didn't jump into that in detail early on, but if each of you could sort of go through and see what kind of data, like, because we think about data streams, right? What data inputs then result in data visualizations or computation of that data. So can you just sort of list off just a lightning round of things that you've seen integrated through virtual care? And we'll go through the panel.
Sure. You want me to start first? I guess I'll say, that, in terms of quickly, I touched on one, which is the patient-provided data, right? Either manually entered, self-reported, what medications are you taking, what symptoms do you have, what devices do you want to connect to the EHR? And then we also have information about what's the provider trying to communicate to the patient, right? So how do they communicate it? You know, what are the pre-procedural things they need to do before they come in for surgery or come in for a pre-anesthesia visit? What are the things that you need to answer before you come in for a clinic visit to make that interaction really go well? And so categorizing the data, figuring out ways to collect and use the data, and then put it in a way that's digestible and usable is really a big challenge. And so I think that's going to be so physiologic data, information about the patient's conditions, medications, lab results. Those are all big things that are going to be important for the future.
Great. Barbara Jo, what kind of data do you need at the bedside? I mean, we talked about hemodynamics, but can you just sort of list off sort of devices that you see that are important for you and your team?
I mean, like I said, we hardly have enough real estate on the patient to put all our monitors on. That's how many we use. And, you know, we want all of that so that we can, you know, like a conductor in an orchestra, you need to know that the second trumpet on the third row is out of tune. Like, I need to know all of it. And so the picture has to be complete. And so I think that SickBay really gives us the ability to put it all together, ventilator waveforms, you know, with all the respiratory. And then the labs coming through real time and then medication administrations coming through real time are really going to be important. And those are the things that we're looking forward to. Real-time medication administration isn't what we have right now in the lab, so that when we have extracorporeal membrane oxygenation, so, you know, mechanical support outside the body, like I need all of that data too, right? So like that is in a separate patient when we have mechanical support. So, you know, I think as we now have become more attached to our sickbay monitor. We're going to only want more and more so that we can then really hear the entire symphony around the patient.
Ken, when you look at the entire, virtual care delivery, I mean, you have a lot of different technologies involved. What are the type of inputs you're looking at from an IT perspective?
Well, I'm working with our critical care clinicians and our, and the people at the front line. They tell me typically, right? I mean, what we're looking for is we're looking to extend the existing data set that we've already created, right? It's pretty extensive already. And to your point, that we have labs and all the Epic, clinical data that's being fed in, and then of course the waveforms, right, and the ability to analyze those real time, and then alerts and alarms. And so expanding that to include different types of devices as they become onto the market, I mean, is something that we're going to be looking to progress. And like we talked about, I think we've all talked about it, that some of that might be in our inpatient settings and some of it may be outside of it eventually, right? And that could be really cool too, extend, including true, remote data. Right now, we're talking about remoting, critical care data, physiological data from the patients that are in our inpatient setting. But I do see that extending out pretty quickly.
So going from that, another question that we had from the audience was talking around alerting algorithms through your physiological monitoring, so the data you're taking and transforming into that. And I think the question was, are you using your EHR to do the alerting? Are you using your physiological monitors to alert? Are there additional clinical decision support vendors that you're using in that mix to actually do the alerting and the analytics on the data you guys are collecting?
So, I mean, we partnered with MIC to build algorithms on top of sickbay to alert our clinicians to conditions that they prescribe to us. How many of those do we have implemented today? I actually don't know the number. I think it was over 20.
Oh, it's over 20, yeah. And getting more advanced.
and getting more, right, and they're growing them now. Those are implemented carefully, right? And but we started with a kind of a base that we felt were necessary as we implemented the system for our virtual ICU, and that work is now continues to expand and grow. And I think as we become more mature and advanced in building those models, I think that's also an interesting area, right? To be able to, you can back test models based upon data that you've persisted from a subset cohorts of patients over time. I mean, that is the really, really cool stuff. And we're looking at that both, clinically, but also in our Center for Outcomes Research.
And Barbara Jo, I know you guys have had experience with models. You've talked a lot about it on this webinar already, but can you talk about a particular model or somewhere you've had success within analytics using this virtual data?
Yeah, so I mean, easy algorithms that look at an hour before a vital signs before an event, or a minute medication administration and then an hour after, to see if that medication is actually causing hemodynamic changes different than we expect, or some small subtle changes that actually over time added up could actually be very dangerous to our most fragile patients. So we have looked at those models. We've used those algorithms lots of times. I think the more interesting thing too, and I'll echo Ken again, is that the predictive modeling, where we can build a relative risk algorithm with multiple different vital signs that are pertinent to its particular cohort or in our ICU. The relative risk predictor ability now with this data is going to be very soon, I think, in the future. And we won't only have heart rate and blood pressure and respiratory rate, but we'll have a relative risk that then is another vital sign. I think that that rich data is going to really point us to that direction. And then the relative risk will be an alarm for us rather than just changes in our usual hemodynamic data. I'm really excited about that predictive ability.
Fantastic. And David, I know Johns Hopkins is big into precision medicine, and you guys are investing a lot of resources in this as well as an institution. You want to say a few seconds about that?
Sure. So you're right. We actually do have a large precision medicine program. It's actually centered on a couple of different technologies. So first off, because we have so many disparate systems in-house, we did build our own precision medicine platform using a combination of open source tools and Microsoft Azure as a storage mechanism. And we also take advantage of some of the built-in mechanisms within sickbay or within Epic to do some other either analytics or predictive analytics in some areas. We're not as far along as our colleagues at Texas Children's and Houston Methodist in terms of actually seeing the proof of those yet, but we've got a lot of research projects in the queue to look at everything from calculating resting metabolic rate for using things like VCO2 and VCO. I'm sorry, VTE2. Sorry, volume of carbon dioxide and volume of oxygen output, I should say it that way. And then we're also looking at things like predicting respiratory decompensation based on some of the metrics that we're able to get. So basically using data from different sources like sickbay, like our VNA for imaging, like our precision medicine platform, like our Epic EMR, pulling all that data together and plugging in algorithms so that we can sort of test hypotheses to figure out, what kinds of things can we do that will improve care using the bench to bedside model that we want to use as a foundation for our medical care.
Well, this has been a fantastic conversation. I really thank all of you guys for your time. Before we hand it back off to Sean, I wanted to give everybody a chance to sort of leave the audience with a final thought. I think for me, when I look at the panelists here and I look at our conversation, to enable virtual care, it's something that impacts all layers of the organization. And I think it's really important when your peers are looking at this, and they want to know, can I do this? Can my institution do this? What is the one thing you'd leave with them, from our conversation today that you think is important for them to take away? Who wants to go first?
It's a journey. And also that would be my advice, and that it requires a lot of different stakeholders. And if you're the opportunity really is now because of the impact of the pandemic, frankly. So if you were thinking about it and you have the available stakeholders, my advice would be to get them together and get after it.
I think what we've learned most is the flexibility is important, and the being able to pivot with agility was very important. But also, pre-COVID, we felt like we might have been riding a bicycle, and then post-COVID, we're in the Ferrari. And I think that the investment in the Ferrari, for those of you that are just starting, is important. And I think that, you purchase the Ferrari and you learn how to use it rather than, settle for the bicycle. I know that analogy might, be a little bit kind of, kooky, but at the same time, it's really true that you make the investment for the big thing, because the next pandemic's going to come, the next crisis is going to come, and you want to have the tools already available to you. And I think that's where we have really benefited, that we were able to just jump in and use what we already had. And I think that's what you're hearing from a lot of people here too.
Emily, David?
So from Medicare's perspective, I think obviously virtual care is really important. We've learned that, but we need help from our stakeholder community when it comes to how we sort of deal with issues like coding and payment, and also quality of care and program integrity. And it's just really, really important for interested stakeholders to communicate with CMS. Either, you don't necessarily like in any way come meet with us, comment on our rules, like all that engagement is really important to us. And it's really important in terms of sort of from a payment perspective, making some of these flexibilities permanent.
David, you're going to finish us off here.
Thank you. I appreciate it. So I'd say three things. The pandemic was really great at organizing us around one set of priorities. And it's really hard post-pandemic to sort of figure out where your priorities are going to be. So first thing is figure out what your high value projects are and high value opportunities are. Second, make sure you've got the right technology to engage, to use those, to sort of solve those problems with technologies. And finally, to quote Deming, right, get the right people organized into a team, get the right people on the bus, the right people in the right seats, and the wrong people off the bus. If you've got the right team, the right technology, and the right priorities, you'll succeed.
Thank you guys so much. Again, it's always a pleasure. And Sean, I'm going to hand it back over to you.
Great. Thanks so much, Dr. Faust. Thank you to all of our panelists for joining us. Thank you to Med Informatics and Intel for making our session possible. Just a reminder, folks, the webinar has been recorded. You'll receive an email with a link to the video so that you can view it again. To access additional webinars or get info on how your organization can speak or sponsor, please visit wcwebed.com. Thanks again for joining us, everyone. Have a great day. And this now concludes today's discussion.